welcome to the Neuroscience Center. My name is David Murray. I'm the Director of the Office of Disease Prevention here at NIH and Associate Director for Prevention. I'm pleased to welcome you to our 2018 ODP Early-Stage Investigator lecture. Dr. Jacob Bohr, who was our speaker for today, is an assistant professor and the Peter T. Paul Career Development Professor in the Departments of Global Health and Epidemiology at Boston University School of Public Health. His research applies the analytical tools of economics and data science to the study of population health. It's a very interesting combination. He focuses on HIV treatment and prevention in Southern Africa. His current research interests include chronic disease management in low resource settings, economic spillover effects of HIV treatment, decision-making in HIV endemic risk environments, population health impacts of social policy, and causal inference in public health research, a topic that is near and dear to my heart. His work has been published in Science, The Lancet, PLOS Medicine, Epidemiology, Health Affairs, all very good journals. Prior to his graduate training at Harvard, Dr. Bohr worked with an HIV prevention NGO in Botswana, Lesotho, and South Africa. He is a faculty affiliate at Boston University's Global Development Policy Center and junior faculty fellow at its Hariri Institute for Computing and Computational Science and Engineering. He is a senior researcher at the Health Economics and Epidemiology Research Office and a visiting researcher at the Africa Health Research Institute, both of these institutions in South Africa. Please join me in welcoming Dr. Jacob Bohr, the winner of the 2018 ODP Early-Stage Investigator Lecture Award. He will speak to us today on the promise and pitfalls of HIV treatment as prevention, quasi-experimental evidence from South Africa. Dr. Bohr.
Thanks very much, David. So it's a real pleasure to join you here at the NIH. I'll talk to you today about some of my work from South Africa on the promise and pitfalls of HIV treatment as prevention. Before starting, because this is a medical audience, I have no conflicts of interest to disclose. I would like to, of course, start by acknowledging some of the very generous funding support I've received from NIH as well as from other funders, including the K01 award from NIMH, Economic Health and Behavioral Dimensions of HIV Treatment Scale-Up, which has really been foundational in my career at this stage. I'd also like to acknowledge my primary mentor of that award, Till Bernighausen, and some of my other mentors at Boston University, Sidney Rosen, Matt Fox, Bill McLeod, and Sandro Galea. So the fundamental question in HIV prevention is how to change the context in which people are making risk decisions in terms of their behaviors. And one of the fundamental determinants of risk is the prevalence of infectious HIV among people's sex partners. So here's a population in which 1 in 20 people is HIV infected and infectious. Here's a population where 7 out of 20 are infected and infectious. In the parts of the world where I work, this is the prevalence of HIV amongst reproductive age adults. My work is largely in Southern Africa, these days largely in South Africa, and as you can see from this map, this is the region by far hardest hit by the HIV pandemic globally. 7 million out of the 37 million people infected with HIV globally reside in South Africa. And within the country, prevalence rates amongst pregnant women reach almost 50% in some areas. So we're really in this world. And so what if there was an intervention that could actually move us from this world into a different world? A world that looked like this, where people were still infected with HIV, but could no longer transmit the virus. And so we had a situation in which our person over here on the left therefore faced a lower risk of infection because of this structural difference in the context. This is the promise of HIV treatment as prevention. Antiretroviral therapy came on the scene in this country and in South Africa in 1996, but was only available in the public sector, in the private sector there. Public sector rollout was delayed substantially and did not start until 2004. But from that point, it accelerated quite rapidly. And by today, there are about 4 million people in South Africa who are on antiretroviral therapy. This increase in South Africa and throughout sub-Saharan Africa was driven substantially by U.S. government funding. And this is an important thing to sort of acknowledge and recognize, that this was a bipartisan effort to devote substantial funding both to research and direct service provision of HIV treatment in low and middle income countries. The population level impacts of HIV treatment scale up in South Africa have been tremendous. So these are data from rural South Africa from some of my work, working with the Health and Demographic Surveillance site, the Africa Health Research Institute. What these data show is that, so here on the x-axis we have year, and on the y-axis we have adult life expectancy, or the age that someone could expect to live to. What we see here is that life expectancy was declining in the early 2000s, but starting in 2004 with the public sector rollout of treatment, life expectancy increased dramatically. And these are now updated estimates through 2015, but the increase has been 18 years in the last decade or so. So these population level impacts, these direct health impacts of treatment as treatment, have been quite large. In recent years, though, we've entered a new paradigm where treatment is not just therapy and life-extending therapy, but also prevention. And so the HPTN 052 trial, which was initially published in 2011, there was a recent update in 2016, randomized immediate versus deferred therapy to serodiscordant couples, and found that immediate antiretroviral therapy substantially reduced transmission in these couples. So in the deferred arm, the standard of care arm, which is over here, there's substantial transmission, and this was reduced by 96% in the immediate treatment arm. So this is sort of the strongest evidence we have for treatment as prevention. It was also supported by another recent trial, the Partners cohort, which was a cohort study and found that in nearly 60,000 condomless sex acts, there were 0 transmissions. And so this has sort of given rise to a new paradigm where having an undetectable viral load and being suppressed actually means that you can't transmit the virus. And there's been a push for campaigns around this, primarily in high resource settings, and we're starting to think about this question in low resource settings. Models predict that if there was mass testing and mass treatment of people who are screened positive, then because of the benefits of treatment as prevention, rollout of antiretroviral therapy could actually end the HIV epidemic. So this green line here shows what would be predicted in terms of HIV incidence under the scenario of universal voluntary HIV testing and immediate treatment uptake. Now, universal voluntary testing and uptake are tall asks, but this at least shows you conceptually where we could get to. In 2015, there was a major change in international treatment guidelines by the WHO, which sought to capitalize on these prevention benefits of antiretroviral therapy and announced a shift in their criteria. Rather than waiting until patients had a lower CD4 count and were sicker, as old guidelines specified, these new guidelines stated that everyone should start ART at diagnosis. And the rationale here was really treatment as prevention. There were a couple of studies that precipitated this change in guidelines, which showed that it was better for the health of the patient to start immediately rather than to delay. But the bulk of the benefit was really in prevention, and that was the main reason for these guidelines. This is really a paradigm shift. Before these guidelines, we were talking about universal access to treatment when people needed it. And after these guidelines, we're talking about treat all. We're talking about universal, not just access, but universal uptake. How do we get everyone to start treatment? Not just for themselves, but for the prevention benefit as well. South Africa rolls out these new guidelines extending universal eligibility for ART in September 2016. So although there's been substantial evidence on the clinical efficacy of HIV treatment as prevention, there's less evidence on the real-world effectiveness in populations. When we ask about real-world effectiveness, There are different ways to learn about real-world effectiveness. One is in population-based trials. There are a number of these that are ongoing. We have results from, I think, just one of them right now, which I'll talk about in a moment. Results from the rest of them will come out in the next couple of years. So we'll have some more information about this coming up. But even in the setting of these pragmatic trials, although there's strong internal validity, what we learn from one of these trials in one setting has to do with that intervention done in that setting. And when we move from efficacy to effectiveness, a lot of what determines effectiveness has to do with the context, the epidemiological context, the cultural context, the behavioral context. And so we really don't just need 5 or 6 of these. We need dozens and dozens of these studies to try to figure out how countries can move towards scaling up treatment for everybody. And in order to do that, we're not going to be in an RCT world, because we won't be able to demonstrate equipoise, and it will be too expensive. And so we need to actually be in a quasi-experimental world, where we're combining routine administrative and clinical data, creating new opportunities with new data sets, and combining those with quasi-experimental methods in order to identify causal effects of interventions. And I'll highlight 2 activities that I've been involved in. One here has been to promote the use of regression discontinuity designs in epidemiology and public health. This is a study design that leverages the quasi-random assignment of treatment at a treatment threshold. So I'll give you an example in a minute, but you can imagine that someone's eligible for HIV treatment if their CD4 count is below a threshold value, say 500. And the person is eligible immediately if they're below 500 and not eligible if they're above 500. Right at 500, those people are really quite similar. And so we can use that as a natural experiment to identify causal effects of immediate versus deferred treatment. And there are lots of these sorts of examples. So we have a study here in Epidemiology in 2014. In Journal of Clinical Epidemiology, we had a lit review of the state of regression discontinuity use in public health and medicine, and identified only about 30, I think it was 32 studies in PubMed. If you did that today, it would be several hundred. So this is really catching on, which is exciting, but is a promising method here. The second activity I'd like to highlight, because I'll show some results from both of these, is work that we've done in collaboration with South Africa's National Health South Africa's National Health Laboratory Service. In the United States, we have a rather fragmented health information system. We have insurers, we have labs, we have hospitals, and everything is rather siloed. In South Africa, the public sector health system provides care to 90% of the population. And there's a single laboratory service that does all of the laboratory services for that public health system for that 90% of the population. And we've been working with NHLS to turn this database into something that can be analyzed as a research cohort. And so one of the limitations of this database is that there's no unique identifier. And so we've been working with NHLS to construct a new record linkage algorithm that uses some graph-based or network analysis concepts in order to construct a unique patient identifier for the first time. And what this allows us to do is it gives us a vantage point on the entire public health HIV program in South Africa. It's enabled government to track how facilities are doing and has been used as an input in some of their dashboards, and has promise as an opportunity to think about how to evaluate these changes in policy in South Africa. So let me go back to the question about, that's how do we learn about effectiveness. Let's just to go back to the question about, can TasP be effective at the population level? So we have some evidence, early evidence from this ANRS TasP randomized trial in rural South Africa, which randomized communities to treat all versus standard of care. And the intervention communities had household-based HIV testing, referral to treatment, and they had universal eligibility if the person was diagnosed. Unfortunately, this intervention had zero effect on HIV incidence. In looking a little bit closer, there was a good explanation, is that this intervention led to similar rates of HIV testing uptake across treated and controlled communities, similar and low rates of linkage to care, and similar and low rates of ART uptake. So the intervention, even though it extended eligibility to everybody in the intervention communities, didn't result in higher uptake in the intervention communities, and therefore didn't result in lower incidence. And so this isn't a refutation of the clinical efficacy of treatment as prevention, but raises the question, how do we translate efficacy into real-world effectiveness? And I think it shows very clearly that effectiveness depends on behavior and not just on biology. Specifically, what behaviors are we talking about? Well, we need people to be diagnosed. We need people to be linked to care. We need people to start treatment. And we need people to stay on treatment and adhere and become virally suppressed. And if they do that, they will not just have lower HIV morbidity and mortality, but will also be less likely to transmit HIV to others. UNAIDS has set goals of reaching 90% at each of these steps as got signposts on the way to the scale up of treat all. So our data from the National Laboratory Cohort and from other South African data sets suggest that treat all will really be a challenge. So there are about 7,000 people in South Africa living with HIV. This is in 2016. We estimate about 61% of these are in care, 50% are on treatment, and 40% are virally suppressed. And so this will be a challenge. And there's rather far from, these are the 90-90-90 targets that we're rather far from. And so there are gaps at each of these stages. So first, many people never seek care. Second, many of those who seek care rather late in HIV infection. This is a distribution of first CD4 counts amongst patients presenting in 2016. And what you can see is the bulk of this distribution is in the advanced disease, fairly sick range. If people were seeking care shortly after infection, we'd expect the bulk of the distribution to be above 500. Conditional on seeking care, many who seek care don't go on and start treatment. So this graph these are data from rural South Africa, which show that between a half and a third of patients who are presenting for care and are eligible for treatment don't go on to initiate treatment. And then finally, of those who start treatment, many are not retained in care. These are results from the National HIV Cohort. What these two lines show is actually interesting. So the dotted line shows the proportion who are retained at the initiating clinic, the place where they started treatment. The solid line here shows the proportion that were retained within the entire national ART program, which we can observe for the first time because we observed that whole program. And so when we allow people to sort of transfer to other sites, retention is higher than it would be estimated otherwise. But we're still losing half of people off of treatment in over 6 years. So these results suggest that removing CD4 criteria alone, in the absence of other interventions, will be unlikely to achieve these 90-90 goals and unlikely to lead to the massive influx of people onto therapy and staying on therapy that would be necessary to really reap the full benefits of treatment as prevention. So this is a daunting task, but perhaps one that we know something about how to do. So how do we motivate greater uptake of early treatment? I would argue that there are sort of two competing perspectives on this. One perspective is what I'll call the cascade of care perspective, which is that patients are stalled essentially at these discrete decision points. Patients haven't yet tested, we need to get them to test. They've tested, but they haven't yet linked to care, we need them to link. They've linked, okay, now we need them to start. And essentially, patients have demand for treatment, but they have difficulty translating those intentions into actions. And we need to remove obstacles from people's way, streamline clinical procedures, and essentially help people to realize the decisions and behaviors that they would like to have. Okay? We need to nudge people along this cascade. A limitation of this is it assumes that people actually want to start treatment. And so another perhaps competing explanation is that, well, maybe some patients actually don't want to start treatment. And so we need to consider that patients face demand for treatment, which may be high or low, may vary. and that this may affect care seeking throughout the cascade. And this is a different sort of perspective on how we might think about interventions, where here the goal is to change the actual, or at least perceived, costs and benefits of treatment. This schematic, which I apologize might be a little bit small in the back, outlines the sort of decision-making process for someone who's thinking about how to start, whether or not to start treatment. And so what you have here on the left is an individual who's nested within their household and community and health system and policy environment. And all those factors determine the actual costs and benefits of starting treatment. Okay? And then this person needs to actually perceive those actual costs and benefits and form some sort of intention based on those perceptions. And then once you have this intention, you have to actually translate that into this action of starting treatment. And we can intervene at each of these steps. And so the cascade perspective says, well, we really need to focus on these barriers and facilitators at point of care. And that's where a lot of the research thus far has been. The demand for art perspective says, no, we need to focus on the actual costs and benefits and the perceived costs and benefits of starting. And so I'll talk a little bit about both of these approaches. And as you might imagine, I'll argue that we actually need both of these. But to think about how these actually work together. This schematic is currently under review, but is part of a project that we did to do a qualitative meta-analysis of the literature on why people don't start treatment. So hopefully this is something that will be shareable soon. Okay. So how can we eliminate obstacles in the HIV care cascade? Much of the current research focuses on this. One key barrier, now fortunately removed, was the requirement of a low CD4 count for ART eligibility. And I think this example is instructive. So we published a paper in PLOS Medicine last year, which looked at retention and care amongst patients who were presenting with a CD4 count close to the 350 threshold. This was using data from a few years ago, but comparing patients who were immediately eligible for therapy, those below the threshold, and patients who were not yet eligible for therapy, those above the threshold, and who were therefore referred to pre-ART care, which meant that they were instructed to come back to the clinic every 6 months for reevaluation to see if they were ready for treatment. Okay? So both of these groups should have been retained in care. One should have been retained on ART, the other should have been retained in pre-ART, in continual monitoring until that person was ready for treatment, at which point that person should have been initiated. The reason we did this study was because although there have been clinical trials, the Temprano trial and the START trial in particular, that have shown the biological benefits to immediate ART, the behavioral impacts of immediate eligibility and immediate ART were previously unknown. So in a trial, you have your treatment group and you have your control, your immediate ART group and your deferred ART group, and you're following them over time. And you're very carefully monitoring both of these groups, and you're evaluating clinical endpoints, which is great in terms of clinical efficacy. But if what you care about is real-world effectiveness, your control group is not receiving standard of care because they're being monitored very carefully. And so what we need to actually do is look for a natural experiment in a real-world setting where we can compare, well, what happens to someone if they're not yet eligible? Do they stay in care? So these are the results from this study. We found that immediate eligibility, let me just describe this chart for a second. On the x-axis, we have the value of the person's first CD4 count. Okay, so these are all people who are presenting for care. We're starting the clock in terms of their follow-up at their first CD4 count. So at this time, the threshold for eligibility was 350. On the y-axis, we have the proportion who started treatment within 6 months. Okay? So what you can see here is that there's a major discontinuity here, or a gap, at 350, with about 25 percentage points. So people who are eligible were 25 percentage points more likely to start than people who are not eligible. Okay? And these people just above and below are similar on all factors, just like in a randomized trial, right? Just in this narrow window around the threshold. Moving to retention, what it looked like was that being told to come back later actually led people to drop out of care entirely. And this was something that hadn't previously been shown. And as I mentioned before, this is actually potentially surprising because people are being asked to stay in care and yet aren't. And so this is an intervention where by extending eligibility to someone at baseline, by initiating someone, we're actually increasing retention in care through a behavioral mechanism. And that's something to think about as we contemplate other behavioral mechanisms and behavioral interventions that might streamline the cascade of care and increase uptake. When we compare patients, we can compare patients who initiated ART because they had an eligible CD4 count with patients who did not initiate ART because they did not have an eligible CD4 count. What this chart shows is the treatment and control groups from 3 randomized trials, which compared immediate versus deferred eligibility with the results of our quasi-experimental study. And in these randomized trials, HPTN 052, START, and Temprano, retention was in the high 90s for both treatment and control group, right? Because they were very explicitly, this is a high-quality randomized trial. You have retention in both of these groups. And in our sample, if you focus on the people for whom that treatment threshold bound, retention increased from 21% to 91%. So we've also shown other benefits of immediate treatment on health and survival, HIV incidence in the household, and HIV testing. And there are other ways to remove obstacles in the cascade. So some of the current discussions have to do with starting treatment on the same day as diagnosis and with moving treatment initiation from the clinic to the household. And there's been some very exciting results in the last couple of years around these interventions, which are promising. So we can streamline the cascade, but one of the limitations here is that if we don't change underlying demand, we may not actually lead to sustained behavior change. Okay? So we may also want to think about increasing costs, increasing the net benefits of treatment. In thinking about the costs and benefits of treatment as prevention, it raises these sort of 2 classic behavioral problems in public health. Okay, so the first is the question of how do we get people to engage in long-run chronic disease management? Okay? These are upfront costs and hard habits to form, hard behaviors to change that require significant effort upfront and where the benefits are going to occur far down the line. And that's difficult. It's difficult for people to do with diabetes and hypertension. It's difficult for people to do with HIV treatment. The second is the control of infectious disease. Because of the prevention benefits of treatment, the benefits accrue to society and not just the individual. In economics, this is known as a positive externality and will lead to suboptimal uptake of treatment relative to the social optimum. Okay? We want more treatment than people want for themselves because we value as society the prevention benefit. And there are other examples of this like bed nets and vaccines and TB treatment. But this is a way of thinking about treatment as prevention that in the HIV field hasn't really been the dominant narrative. It's been much more about moving people through care and thinking less about the fact that we actually value them being on treatment perhaps more than they do in some cases. To this point, although there are clearly direct benefits to immediate treatment versus deferred treatment, on an absolute risk difference scale, these benefits are relatively modest. Okay? These results are from, this is a reanalysis of the Temprano and START randomized clinical trials, which were part of the basis for the revision of the WHO guidelines. So these trials showed unequivocally that it's better to start someone early versus late. So that's not the argument. But that was true on a rate ratio scale. So it reduced the risk of morbidity by about 40%, 44% in the Temprano trial, and almost 60% in the START trial. But the baseline morbidity in the control group was pretty low. And so on a risk difference scale, we're talking about a reduction of 1.7 adverse composite endpoint morbid events per 100 person years in Temprano and less than 1 per 100 person years in START, implying a number needed to treat of 60 to 120 person years of treatment in order to avoid one non-fatal morbid event. Now, I guess I should say whether that's big or not depends on your perspective, right? And that may be big for some people, and it may be small for other people who face larger costs of seeking treatment. Again, this is not to say that people shouldn't start treatment immediately. They should. But that's the clinical advice. And the clinical advice needs to be thought of in the context of people's lives. So what is that context? We collected some data on the costs of care seeking for what is nominally free antiretroviral therapy in rural South Africa. And when we added up the costs of travel time, time at the clinic, additional costs they spent on self-care and on private doctors outside the health system, transport costs, this amounted to about a third of per capita income in the area. And about 40% of the people in this study reported that they had to borrow money or sell assets in order to pay for care. So even though treatment is free in South Africa, there are still expenses. And so when we're thinking about people's decision-making process, they face some benefit, but they also face some costs, including some financial and time costs. There are also significant non-financial costs. So we conducted a qualitative meta-analysis to look at why patients don't start treatment. We thought this would be an interesting population to look at because if we care about demand, then let's look at a population that we know by their revealed preference has demonstrated that they have low demand for treatment. So what are the costs that they perceive? And some of the things that came up in this meta-analysis included the hassle of daily therapy, included the perceived side effects of ART, included exposure to HIV stigma and potential rejection from sex partners, and the mandated lifestyle changes that the clinics promoted as a condition of getting onto treatment. So we have some good evidence that we can do something about these costs and have done something about these costs. So I'll tell you a quick story about a study, another quasi-experimental study that we did here, looking at the impact of fixed dose combination, which is one pill once a day instead of many pills a couple of times a day. And this issue of having large pill burdens is something that obviously plagues us in this country too, and is something that it was hoped would really, by moving from 3 pills to 1 pill, it was hoped that this would improve adherence, improve retention and care, and lead to better outcomes, even though the drugs worked exactly the same way. So this is not a change in the efficacy of the treatment. This is a change in the packaging, essentially, to see if this would lead to increased retention and care. So we did a regression discontinuity design. This will be a theme here, to look at the impact of starting fixed dose combination on retention and care. And we used clinical records from an urban cohort where we had pharmacy data in Johannesburg. And what you can see here is that this intervention was rolled out very rapidly here. So if you started treatment before April 1st, then you were almost certainly prescribed multiple pills. And if you started treatment after April 1st, then 80% of you were prescribed this single pill therapy. And what we found was that this actually substantially reduced attrition from care. I find this surprising because if I really wanted treatment, then what difference would 3 pills versus 1 pill make? But actually those are real costs to people. Those hassle costs are real costs. And that's what this highlights. This shows the results for attrition from care, and this shows the reduction in the proportion who are not monitored for viral suppression. So there are other ways to reduce actual costs. We can create drugs that have fewer side effects. So one of my collaborators at Boston University, we have an article coming out in the American Journal of Epidemiology where we look at the switch from stavudine to tenofovir. So tenofovir is a drug that has quite a low toxicity profile, is not so bad to take. Stavudine was really toxic, and it was sort of a nasty drug, and it had really negative side effects to the point that a lot of people actually had to switch off of it And so we looked at what happened when people were started on tenofovir instead of stavudine. We found that, lo and behold, actually that improved retention and care to be started on a drug with fewer side effects. Again, this is really not about the efficacy in terms of fighting the HIV virus. This has to do with how easy it is to take these medicines. And so there are things like this that we can do. Probably the classic approach in economics to trying to solve the externality problem is to pay people. And there have been a number of efforts to do this, and they've really had mixed results. I won't get too much into this, but there's mixed evidence, and there's also questions about how scalable these sorts of interventions would be. Finally, our review really highlighted these lifestyle requirements that people were being asked to make as a condition of starting therapy. And I haven't seen a lot of work on this, and maybe there is, and I'd love to hear from folks if so. But people really are being asked not to drink, not to have unprotected sex, and to disclose their status to partners as a condition of starting. And in an age where we know that HIV treatment actually virtually eliminates transmission, it's not clear that this is really evidence-based. And it has the effect here of discouraging people from starting. So that's more of a hypothesis there that I'm laying out here that is worthy of investigation than a hard statement. But we know here that people are reporting that they're not starting because they feel like they're being asked to really change too much about their lives. So in addition to the actual costs and benefits, we need to think about the perceived costs and benefits. One of the things that came up in this qualitative meta-analysis was that people's perceptions were really formed during the initial era of ART rollout, a time when people who were starting treatment were very sick and dying, a time when people were starting regimens with lots of side effects and hearing about that from their neighbors, that, they change the way your body looks like, they have terrible side effects, these are nasty things to take, don't do it. And so people's perceptions were formed 10, 15 years ago, and we need to sort of reset people's perceptions based on the current technologies. Perhaps the biggest gap in knowledge, though, may be with respect to treatment as prevention itself. As I said before, prevention is the primary rationale for immediate early treatment. This plot shows the modest reduction in clinical events, the sort of direct effect with immediate ART compared to the very large reduction in transmission risk due to immediate ART. So this is really the primary rationale, and yet it hasn't figured into national counseling guidelines. Counselors that I've talked to haven't known about treatment as prevention. A colleague did a study where he recorded counseling sessions, and there was no mention of treatment as prevention. I think this is starting to change, but these data have existed now since 2011. And this is in spite of the fact that treatment as prevention is by far the best secondary prevention strategy. So these are data from an article that looks at the 10-year transmission risk in a serodiscordant couple under these three secondary prevention strategies. So imagine a couple, one is HIV positive, one's HIV negative, and they use condoms. That's here in the middle. After 10 years, the transmission probability in that couple is about 10%. With use of PrEP, it's pre-exposure prophylaxis, which there's a lot of excitement about these days. It's about 15%. With ART, it's less than 5%. Okay, so treatment as prevention is a really good secondary prevention strategy. And there's qualitative evidence that people actually prefer it to other methods. And so there's sort of a question of why should we be moving more in this direction of giving people this information? We want to know what people actually believed in the population-based context. And so as part of my K research, we conducted a survey of 425 young adults in rural KwaZulu-Natal, South Africa, And these are current data. So this is from September through December of last year. And we asked people about their beliefs about the HIV risk environment. And we did it in an interesting way, which is that we gave people 20 beans, and we had them allocate them. We asked them about the chances that something would happen, chances out of 20 that it would happen, and have them allocate those beans into the chances that it would happen and the chances that it wouldn't happen. So, we would ask them, what are the chances it's going to snow next year? And so they would put, most of the beans here, and it's not going to happen. We'd ask them, what are the chances that that they'll graduate from high school? And different people would give us different answers, and so on. And we went through a long validation exercise for this method, which is actually based on methods also that have been used in prior work in Malawi. What we found is that people dramatically overestimated transmission risk on treatment. So the objective risk in a serodiscordant relationship over the course of 1 year is 1%. Okay? The objective risk in a serodiscordant relationship where the person who has HIV is virally suppressed is 1%. The perceived risk of transmission is 75%. Okay? Of course, people actually tend to overestimate transmission probabilities in general, but they do so more for ART than they do otherwise. So this plot shows the relative efficacy of these different strategies, condoms and treatment as prevention, in preventing transmission in serodiscordant couples. So this is like compared to unprotected sex. So 0% would mean you're just as good or bad as unprotected sex. 100% would mean that you have 100% efficacy relative to unprotected sex. You're eliminating transmission. Okay. So condoms have the objective numbers for condoms are that they're about 80% effective, 77% effective, and people have pretty accurate beliefs about that. They think condoms have 70% efficacy relative to unprotected sex. The real numbers for antiretroviral therapy as prevention are 95%. But people are much more pessimistic about treatment as prevention. So if you had to choose between condoms and treatment as prevention, based on the objective evidence, you might choose treatment as prevention. Based on perceptions, you'd clearly choose condoms. So this raises the question, should we rather be selling treatment as prevention on its merits, on the fact that there are these very large prevention benefits, that's why we're scaling up therapy, and should we be telling people this? And if so, how? So I'd argue there's at least 3 good reasons why we should do this, and there are a number of reasons why we might not do this or why this might be difficult, but there are at least 3 good reasons to do this. And the first is that people may value the social benefit. We're having trouble getting people to test and start and stay on therapy. But the fact is that the benefits of early therapy, direct benefits, are relatively modest, and the prevention benefits are very large. And maybe people will value this social benefit and actually choose to test, choose to start, and choose to stay on therapy for this social benefit. There's evidence from neuroscience and evolutionary biology that humans are actually altruistic. And there's evidence from HIV interventions like prevention of mother-to-child transmission that pregnant women are willing to take therapy throughout their pregnancy in order to prevent transmission to their unborn child and through the first couple of months after birth. But what's interesting is that even though formerly pregnant women are eligible to continue on therapy, adherence and retention on therapy plummets once the risk of transmission to their kid ceases. So this supports the notion that that pregnant women are actually acting out of altruism towards their kid or a wish not to transmit the virus. And a similar dynamic could work in sexual partnerships as well. There's evidence from the vaccine literature that when people are told about the social benefit in terms of herd immunity, in addition to their own direct benefit, it actually increases uptake of vaccines, at least among adults. So there's some potential here, but there's a lot we don't know. How should we message this information? it's almost surely context dependent. Different societies, different cultures have different values in terms of whether I care about my partner, my community, society at large, the nation. How we should think about how to message this is really an open question. Secondly, a key finding from the qualitative meta-analysis was that people were not starting treatment because treatment renders HIV visible. You have to go to the clinic, you're carrying around pills, there are pills at home. And people were afraid that if people found out that they were HIV positive, then they would be vulnerable to stigma and that they would be rejected by current partners, by future partners. And this is particularly important for young adults, people in their early 20s, let's say, who, amongst all the things in their lives, among the most important things to them is finding a long-term relationship partner at some point in the next, say, 10 years. So holding up a sign and saying, I'm a high risk of HIV transmission is really risky. And this leads people to fear getting onto treatment. We have some evidence that, from our survey, that having HIV makes it harder to find a romantic partner. So 41% of young adults agreed that if I were HIV infected, it would be difficult to find a romantic partner. Now, that required them to make the cognitive leap to say, if I were HIV infected, and most weren't. Perhaps more revealing is that 78% disagreed with the statement that they would feel comfortable in a sexual relationship with someone who is HIV positive and on ARVs. Okay, so if that response is anything like the other responses in the community, then it's only rational to try to hide your status. And this is all based on the perception, the community level perception, that ART is a signal of HIV transmission risk. When in fact, the exact opposite is the case. So in rural South Africa, in a high prevalence setting, an HIV uninfected person could reduce their transmission risk, their infection risk, by 80% by choosing a partner who is stably on ART rather than a partner of unknown status at random from the population. Okay? So rather than ART being a signal of risk, it's actually a signal of low risk, of protection, of responsibility. And so there's a question, can we change that norm? If we could change that norm, if we could change my beliefs about what the community thinks about my being on ART, then could we actually encourage people to test and get onto treatment earlier? There's some evidence that we can. So Laura Dirksen and colleagues in Tanzania ran a community randomized trial where they actually provided information on the prevention benefits of treatment. This was a trial of 122 communities. And what they found is that providing this information shifted beliefs about treatment as prevention in the direction that you'd expect. It reduced stigma, and it led to an increase in HIV testing. Now, the baseline levels of HIV testing here were low. So it was an increase from 2.6 to 3.5%. So there's an open question here about, can we actually use this logic and this approach to more broadly mobilize testing, treatment uptake, treatment adherence, in the sort of behaviors across the cascade. But this is at least very encouraging data as a proof of concept for this approach. That stigma isn't some unknown thing. It actually has a basis in people's misperceptions about transmission risk. Thirdly, I think it's probably the ethical thing to do to tell people about the transmission reduction with antiretroviral therapy. People deserve to know it if starting treatment can protect their partners. And as we think about combining sort of cascade-based approaches where we're trying to sort of nudge people along the cascade, adjust the choice architecture so that testing and starting are the default options and that sort of thing, we need to make sure that we're not encouraging people to do things that they don't want to do. Okay? And if there's a social benefit to them doing something that they don't want to do, then we need to tell them. Like if we're going to nudge people to take up HIV testing and treatment at levels that are beyond what they would do otherwise for their own self-interest, we need to at least tell them the rationale for that there's a social benefit to you getting onto treatment, and that society has decided that this is a good idea. So can treatment as prevention succeed in South Africa? I would say yes, if. First, if we make it easy for people, okay? These are sort of the cascade interventions. If people want to test and treat, we need to make it incredibly easy for people to implement those decisions. Reducing barriers and supporting them at critical decision points and junctures. By helping people onto treatment, we may actually help them to develop new habits and learn while they're on treatment, learn through experience that treatment is not so bad. Secondly, we need to continue to focus on increasing the net benefits of treatment, and importantly, we need to communicate these benefits to people, which I think we haven't done quite enough. We need to communicate these benefits both at a population level to reduce community-level stigma, and also at the individual level to patients to help support them in their decision-making process. And finally, we need to evaluate the rollout of treat all policies, which are being rolled out right now as we speak, and determine what works. We need to see where in the country this has led to an impact, to a large impact, where there are areas of unmet need, what are the success stories that we can that we can learn from, and think about this as a population-based continuous quality improvement project, where we need to move the health system in the direction of treating everybody. We're not going to get there all at once, but with some of these steps, maybe we'll get there eventually. Thank you very much. I really appreciate your time and the invitation from the Office of Disease Prevention. Thank you.
We have a microphone here in the aisle, so anyone who has a question, please step up. We're happy to entertain questions. We have a little time.
Risa Goldstein from NICHD. That was a fantastic presentation. I was involved in prevention with positives at UCLA about 15 to 20 years ago, and some of what has materialized as reality on your watch was being talked about on mine. Two questions that at least in my experience of having dealt with prevention with positives in the U.S., are tolerability of HART and adherence. Back in the day when I was most involved with this, the conventional wisdom was you had to be basically 100% adherent to make it work, and the tolerability was pretty dismal. The kinds of regimens that are now being rolled out in South Africa, how do those stack up?
Yeah, that's a great question. So, I think in terms of tolerability, things are much better now than they were, for 5 or 7 years ago. And I think that so that's one positive thing, and there are newer drugs that are coming online where that are even more tolerable. The question about there's a question about learning from U.S. contexts, which I didn't address at all, and I think is really important because there are now experiences in high income settings with this sort of U equals U campaign, undetectable equals untransmittable, that I think there's a lot to learn from, and that's a direction that I really didn't mention at all, but I think would be important to think about. Let me leave it there.
Thank you very much. Very nice talk. Paul Gast, Office of AIDS Research. Just a couple of things to ask you about. One, the research that's essentially being conducted around treat all policies, ART, combined with PrEP. So I don't know if you've thought about that in your paradigm and in your modeling, so if you can comment on that. And then also about the evaluation of relative cost benefit within the context of individuals' lives. So whether it's couple dynamics, partner violence, food insecurity, conflict and disaster within their communities, how that may factor in to some of the modeling that you've presented.
Yeah, I think, let's start with the second question. We need to engage people in their context. And I think the examples that you raised there are really good ones and illustrate that if we just sort of have a single approach, where we just focus on finding people, getting them on treatment immediately, and that's going to be good enough, we're maybe not appreciating the context in which they're making these decisions. In some of my conversations with HIV counselors in South Africa, I heard that people are actually a little wary of going to the clinic because they feel like they're going to be pushed to start. So they're wary of getting tested, which is sort of a potential adverse consequence that we don't sort of want to go down that road. So I think we need to, as we work on streamlining the cascade, we don't want to throw out all those adherence sessions and support group sessions and all of those other things that we were doing previously before treatment. We want to make sure that we're still doing that stuff and figuring out how to tie people in to support groups and to services that will help them to, in these initial stages of habit formation around starting treatment. Because people's contexts are going to differ, and because the health system isn't, can't have a different sort of treatment guideline for everybody, but can have these wraparound support structures. And so I think we need to be careful as we move towards getting rid of these steps in the cascade and just trying to collapse things to you get tested, you start, that we're not, that we need to make sure that we're still addressing people's other needs in the context that they're making these decisions. In terms of PrEP, I'm not an expert on PrEP. My sense is that from the perspective of both PrEP and ART, they are substitutes in the sense that the higher penetration of treatment as prevention, the less scope there is for PrEP to be effective, and vice versa. The greater penetration of PrEP, the less scope there is for treatment as prevention to be effective. So, at some point that matters. I'm not sure we're there yet. I think we're at a point where, these are both very highly effective interventions, and if people are in situations in which PrEP would be beneficial and are willing to take up, they should. And I think, one of the lessons from our work on treatment thresholds is that preventing people from doing the public health behavior that they already want to do is a really bad idea. Like, let's let people do the healthy things and then focus on people who actually don't want to do the healthy behavior. And that's a more complicated task. But if people want to take up these preventative behaviors, we should let them do it.
Do we have data on the combined effect of PrEP and treatment as prevention?
I don't know.
If you've got a 95% reduction in transmission, sorry, I don't have a mic over there. If we've got a 95% reduction in transmission with treatment as prevention, and we've got a pretty high reduction in transmission from PrEP, I wondered if we've had a trial looking at the combined versus one alone or neither.
I mean, if the Sarah discordant couple is using treatment as prevention and there's only 1% chance of transmission over the course of a year, there's no room for improvement. You go from 1 to 0.1, which isn't nothing, but once you start layering these interventions, I mean, it's an added safety if, for example, you develop resistance, or if you're not adhering and your viral load goes back up. So, from that perspective, that might make sense as a way to layer these interventions. I think in South Africa there have been trials and demonstration projects, but PrEP is not sort of widely available currently. So at a population level, we don't know.
Hi, thank you, Dr. Boer, for this excellent presentation. My name is Karine. I'm from UNC. I really like the fact that you looked at perceived benefits as opposed to actual benefits. So how do we go from 75% to 99% in terms of perception of art benefit at a population level? How do we frame, benefits around art? How do we use these findings to influence policies, the governments, for example?
What was this the chart that you're
Yeah, that's it. Yeah.
asking about?
How do we go from 75 to 99%?
So we actually want to go from 75 down to 1.
Down to 1. Sorry, that's what I meant. Yes.
So so what this chart is showing is that people vastly overestimate, right, the transmission risk
Right.
on treatment. I think we start by telling them. I mean, we've spent so much time saying that, AIDS kills, HIV is deadly, you have one sexual contact with someone and you're almost certainly infected. And we've been using scare tactics for the duration of the epidemic. And they've led people, people have learned from that. And they've learned, based on those scare tactics, that they need to be really, really careful about having unprotected sex even once. I was an HIV educator in Botswana before I went back to grad school. And we were telling people that, even if you have unprotected sex once, you can get infected with HIV, which of course is true, but it's misleading in terms of the probabilistic thinking here. And now that we have ways for people to, on therapy dramatically reduce their risk of transmission, we need to message. We need to message on it. So I think we just start by telling people and then figure out how. Or vice versa. Figure out how to tell people, then tell people.
Yeah. Thanks. Stephen Gilman from NICHD. So someone has to ask you a methods question about this regression discontinuity design.
Yeah.
So 2 related questions. The first is, this was the first example I've seen where the x-axis wasn't time. And so I thought that was really fascinating. So the first question is I have the intuition that this has much broader applicability. So under what conditions could we use the regression discontinuity design for other types of situations where it doesn't involve time? And the second related question is, one of the results that you showed, it looked like there was a discontinuity, but it sort of petered out over time and eventually sort of rose up to the original pre-level. And my intuition is that comparison wouldn't be sort of quasi-experimental. But so is it only at the junction, and how can you use the design later on in time?
Thank you for the methods questions. So with respect to the, let me see if I can get back there. Is it this one? Yeah. So, there may be a trend over time in viral load monitoring here. And what it looks like is that there's an upward trend. And so virological monitoring is increasing over time. But in this, because we're only, this is only looking 1 year out for patients initiated in each of these years. But for patients who present just before and after April 1st, the assumption, which is justified by our knowledge of sort of what happened at the clinic, and by some validity tests that we can run, is that these patients are similar. To maybe go back to the non. So I will say that that's not really time there either, because that's date of initiation on the prior slide. So it's not calendar time. These are people initiating before and after a given date. So the follow up occurs on some other the follow up. We're not looking at it's not an interrupted time series where we're looking at a shift in some outcome at a point in time. We're comparing outcomes over time in people whose exposure was determined at some baseline point, depending on when they started. Here we have an exposure that's determined based on what CD4 count they had when they were first assessed, when they presented for care. And, these decision rules, like, and here's the change in initiation probability. These decision rules, like, you're eligible for HIV treatment if you have a CD4 count below 350, these are ubiquitous in clinical medicine. I mean, we have this for diabetes, for A1C, or formerly fasting plasma glucose. We have this for hypertension. We have this for all kinds of things. I mean, continuous biomarkers are only useful if they help us to make decisions. And so we have guidelines about when we're in sort of a sufficiently high-risk situation that we should actually start therapy. So I think there are loads of examples in medicine using these sorts of clinical biomarkers. One of the nice things about the clinical biomarker, this is perhaps a little bit in the methods weeds, but I'm going to go here for just 1 second, is that measured CD4 counts are measured with error. There's sampling variability in these CD4 counts, and there's machine imprecision in these measured CD4 counts. And so that measurement error in these measured CD4 counts has the function of quasi-experimentally randomizing patients with true CD4 counts at 350 to be on either side. So this is a case where measurement error is actually the source of identification, causal identification, and not something that is not a threat to our validity, which is sort of an exciting thing and turns it a little bit on its head from the way we usually think about measurement error. But I think there are lots of these examples. There are examples in terms of elections. Are you above or below 50%? In environmental pollution, are you downstream or upstream of a point source pollutant? And so on. I think there are lots of examples. And I would refer people to our review paper in Epidemiology in 2014 on this. Okay.
I don't have a methods question, but I'm Susanna Allison from NIMH, and it was a great talk, really, really wonderful. I had a question about one of the slides that had talked about some of the barriers to uptake to art and included sort of reducing behaviors that, and I guess this is the part I'm not clear on, is that clinics are asking patients to sort of stop using alcohol in order to go on to art, or is that a perception from the patient's perspective that they can't report their alcohol? They're being asked, and then they don't want to report that when they're going into the clinics, and then they're staying away. I guess how explicit or implicit are those behavioral demands?
So I'm presenting results of a qualitative meta-analysis, which is an interesting thing, because we're taking the results reported in other qualitative studies and the various quotes and interpretation there, and compiling across lots of different qualitative studies and triangulating to identify common themes and structure those themes. But I didn't collect the data. So I sort of hesitate to sort of draw, to draw inferences there.
Okay.
I don't know how prevalent the sort of, you must stop drinking in order to start is. But I do think people are being, there's a whole literature out there that says that, that says that alcohol and ARVs are not compatible. Okay? And it's a self-referential literature because they cite, that statement is made citing studies that show that when people drink, they don't adhere. But the reason people don't adhere when they drink could be that they actually choose not to take their meds when they drink because they've heard that there's a biological link between ARVs and alcohol. And so, I mean, I've done some poking around, and it seems like there isn't much evidence of a biological link. There's evidence of a behavioral link, but the behavioral link could be based on these misperceptions about a biological link. This is not my narrow area of expertise, so let me sort of stop there. But hopefully, I've seeded a few literature searches here.
No, because I think it is important to sort of, because I know there used to be a lot of emphasis in clinics that they would put people on placebos for a couple months just to see how adherent they would be, and if you weren't adherent enough, you couldn't go on art. So that's obviously something, you would have a much different structural clinic-based intervention to address, sort of more of these explicit rules to going on art versus this is my perception. I don't want to tell you about my alcohol use because I don't want to get yelled at again about drinking. Anyway.
Yeah, I think sort of the point I'm trying to make here is that we may be encouraging people to do things as a condition of getting on treatment that they don't need to do based on the evidence we now have. And they may be really significant changes in people's lifestyles. And so I give you the alcohol example, but the unprotected sex example is an even better one. People are still being counseled, here are your meds, make sure you wear a condom every time. So if we're giving people their meds and we're saying, but now you need to use a condom, we're implicitly telling people that these meds don't work at preventing transmission. That's what we're implicitly telling people. And so trying to figure out how to message that in a way that is honest with the science and good for people's health and engages people in how to sort of navigate these complexities on their own, I think is an open area that we need to do more work in.
I'm Jonathan Bohr. I'm a relation. You talked earlier about the ethics of telling people or not telling people that there's a social benefit in starting therapy now. What about and I'm sorry if you answered this, but I might have missed it, the ethics of telling people that there's very little personal benefit of starting now versus starting later? Where do you come down on that?
So I think that the evidence is incredibly strong that starting now is better than starting later. From the perspective, you could not design a study. There would not be clinical equipoise to say that we don't know which is better. We know which is better. It's better to start today. And that's true both for biological efficacy reasons as well as the behavioral reasons that we showed in our study, that if you let someone go out the door, you might never see them again.
Right.
In terms of the size of that benefit, I think it's tough. I mean, I think we focus more on having discussions with people about the costs that they do face and how to limit those costs. I mean, it's clinically better for this person. If it was costless, it would be better for this person to start. So the question then is just, well, what are the costs that this person faces, and are there ways that we can support this person, and whether that's in navigating costs around disclosure, navigating travel time, navigating other costs that they may face. And there are lots of interventions sort of targeting all these different aspects that people are working on right now. But I think I would emphasize the importance of trying to understand what people perceive will be the most likely barriers for them, and how the clinic can support them in navigating them.
Do we have other questions? Listening to Dr. Bohr's presentation today made me think of all of the people who put so much time and energy into the selection process this year for choosing a winner for this award. There were lots of people who were nominated. There were lots of people at NIH who reviewed all of those applications and made recommendations. The selection this year was consensus-driven. It was pretty straightforward. Dr. Bohr was the winner based on everybody's review of the materials, and I think he's validated that quite nicely with the presentation today and the way that he's dealt with your questions. Don't ever be shy about asking methods questions. I'm going to be bugging him about methods all evening at dinner, so don't be shy about that. I've read it. And I've written papers on regression discontinuity, so it's familiar territory. Thank you, Dr. Bohr, very much. Terrific presentation. Thank you.